Good morning, everyone. Today I am presenting Doctor Assistive QA with LLMs. This is my final thesis presentation, and where I will show how I am solving critical problem in clinical practice using LLMs. Let me start by explaining problem I am solving. Medical report often long and complicated, but they are a key guide about what happened next to the patient healthcare. The medical reports are hard to scan and quickly understand, but many doctors and nurses are struggling to find the right detail quickly, which slow the decision making. The study shows clinics spend 35% of their time just searching the right information. Medical errors increase by 50% when relevant information is missing. And the challenge is, actually typical medical report contain more than 2000 words, but the doctor don't have much time. The doctor need to spend probably 3 to 5 minutes for extracting information. It's not about inefficiency, it's about patient safety. So, many systems focus on patient-facing features instead of helping clinics. They measure success with generic NLP scores, not the clinical correctness. When they test on the real data set, like the real medical reports, the accuracy and the performance often drop. So what we need a clinic-focused question answer that give accurate and real case for clinic relevancy and safety. This is what I'm doing with my proposed model, which is DocTalk. So this is the related work and how I overcome that issues. The first model, you can say, it gives the very long answer and it's not good for real purpose. But in my case, I use the real medical reports from Mimic, and I use the ground truth output with LS and CDI codes for better evaluation. The other one is, it just use the Mimic discharge summaries with short context, and that is not good for real time, because in real time we have a long summaries. Like I already told you, the summaries are often 2000 words and more than 2000 words. It depends on your case. So here they use the short context window, so when the text is more than kind of tokens, so that model fail. What I use my model to handle long context, and my data set is beyond the Mimic. And the same thing happened with MediQSum. They are facing only for the patient oriented. They are created data set, but they are not for doctor purpose and doctor question answering. I create the first doctor oriented question answer, which create a good accuracy above the Mimic data set. So this is the research gap and how I solve. First, I create the very first doctor associative question answer, and then the target question answer only because many models are just not giving you the answer, they're giving you the summarized answer. It's kind of, if you ask the answer, they will give the answer, but they will tell more about hallucination part. But in my case, I just focus on the answer, the precise answer, maybe 1 line or 2 line answer. The third is superior accuracy. I got most probably, I think, the very good accuracy, more than any paper. And then the advanced metrics. I also use UMLS and CD code for better accuracy and medical awareness. Okay. So this is the highlights what I create. First, I create the data set. Then I use the fine instruction tuning for 6 LLMs, and after the interactive web design. So this is my methodology and system diagram about how my model work and how I use to create the data set from data collection, pre-processing, model training, evaluation, and deploy to the website. So let's talk about data creation. In data creation, I use mimic medical reports for data creation, and then I split that report into the question answering by using Llama 370B. After that, I use COT prompting for creating the question answer pair, and the final output is the concise question answer only. So this is how I create the data set. So you can see, first I use the de-identify mimic summary. After that, that summary goes to my model. My model use chain of thought by reasoning, and then it produce the answer. So I will doing the question answer for each domain, which is diagnosis, medication, treatment, hospital costs, symptoms and complaints, procedure test, and post-discharge and follow-ups. So after refinement, what I get, first of all, the physician validation. The physician validate the completeness, safety, traceability of the all information. Then I already tell about how and why I use the Llama 3.370B, and after in final data set, I have the doctor oriented question, the medical report, and the concise answers. Okay. So let's move on chain of thoughts. So in chain of thought, I use the first of all system prompt. In system prompt, I clearly define my model, how to do the reasoning and in which patterns you have to follow to do the reasoning. So this is the workflow diagram of chain of thought. So you can see here how chain of thought entirely works. And this is how I use that chain of thought prompting in my case. First of all, you have to give the system prompt to your model, like think about step and give the reasoning in step by step, and the agent or the model will respond in step by step, like they will give you the reasons, and then according to that reason they will give you the accurate answer. Okay, so now let's move to the models, like which models and why I use that models. First, I use 6 models. 3 is general purpose model and 3 is bio LLM models. So let me tell you why I use and why I select that model. First of all, I use Mistral 7B. This is the lightweight model for just to check the LLM in the general purpose way. Then I use Llama 3.38B instruct. This model is widely used in LLM purpose, so I want to check how that model work in a like totally different domain, like domain. If you want to do a domain specific thing, how you can do with general purpose LLMs. After I use Llama 3.8. This is the upgraded version of Llama 3. So I want to know if how the model perform in the latest version, like if someone is launching the latest version, is it really effective or not. After I use the BioMistral. The BioMistral is the domain adaptation of the Mistral 7B. So I want to know that if the company launch something related to the biomedical field, so how it affects and is it good to use or not. And the other one is Llama Med 42B. This is totally the domain specific model. I just want to know whether it is good to use the domain specific model rather over than the general purpose model. And the same goes for Metatron. Okay, so this is my final output of my built-in data set. Actually, I am doing 2 things. First of all, I am creating the dataset. I'm not using any dataset downloaded from the internet and run that. I'm creating dataset which I already explained how I create, and then I'm running that pre-trained models on my dataset to check what is the base evaluation of that model. So then I can compare that evaluation to my fine-tuning part. So here you can see the Llama 3.1 got the highest accuracy. Like you can see the row score is 24% and the bird score 69%. The ULM score is 23%. So by the overall the general purpose LLMs or bio LLMs, the general purpose LLM as a pre-trained model, it effect and it goes the good result. This is the system architecture of how I create the data set and which evaluation methods I was using while to validate that accuracies. So let's move on. Instruction tuning for domain adaptation. Oh, sorry. So to adapt powerful LLM for highly specialized LLM medical domain, I employed the low rank adaptation, which is known as LoRa, for efficient and time efficiently customized model. For model selection, I'm using that 6 model which I already tell you why I'm using and why I select that, and then these are the LoRa configurations and these are the optimized configurations. You can see here I'm using the rank 16, alpha 22, drop down, and the learning rate, epoch, gradient, everything. So this is the comparison of the full version and the LoRa parameter, like after optimizing the model or after running the LoRa. So before that, you can see all the models are approximately 7 to 8 billions. But after implementing LoRa with rank 16, I'm using only 25 million to 29 million, which is only 0.36% of the trainable model. This makes training extremely efficient while achieving the high accuracy. This is the one reason why we use LoRa instead of full training. So before in dataset creation, I was using the chain of thoughts, but in fine tuning or instruction tuning, I'm using the few shot technique. So how few shot technique work? In few shot technique, you have to give the example pattern and the answer about the negative answer or truly answer, whatever your data set is, and then you have to give your new answer, and the model will generate the answer by learning patterns from these examples. So this is the system architecture of how I'm using the instruction tuning for evaluation LLMs. So what is my novelty here? Like everyone is using that kind of thing, so why I'm using that? Actually, if you see the latest paper or the old paper, they are just using the textual metrics like the row score, the bird score. They are good, but they are not creating anything in the medical field or like clinically awareness. But in my case, I'm using that also, but in advance, I'm using the ULM score and the ICD scores. The ULM score evaluates the precision and recall for biomedical entities from unified medical language for system conceptual answers, and the ICD F1 assess the accuracy of valid clinical coding in the international classification disease using the model answer. This dual layer approach ensures that generated answer is not grammatically correct but also the clinically accurate. So this is the example of why we have to use the the clinical metrics over the generic NLP metrics. So you can see this is the ground truth answer. The patient might prescribe Valium for prevent seizures. But if you go for that answer, the model A answer, they just tell they are giving any antibiotic to fight the infection. If you go for the BERT score or ROG score, they are semantically same and they are fluent. This is how the ROG score and BERT score evaluate the test. But if you go for ULMS score, the specific antibiotic name is missing and the CD code is 0 because there is no specific diagnosis. But if you go for the other information, they are giving they were given an Valium for seizures. So here you can see in the model B the antibiotic name is there. That's why our UMLS score is high and the ICD code are provided. So it will also give the high score. So this is how you create the clinical accuracy, how you measure the clinical accuracy. So this is the evaluation or like work framework, how I'm using, like what I'm using, like how I create load, how I create the few shot technique, which parameter I'm using for creating the scores. So now let's compare to the let's go to baseline model and fine-tune model performance comparison. So this is the graph for UMLS score. So here you can see for biomixture it goes around 4 times. Like in the base version it's only 0.11%, but after instruction tuning it goes 41%. It's kind of 4 times above that score. The same for Meditron, like lightly double than the score. And then for there is also like the Met 24 and the so on. You can clearly see why we have to do the instruction tuning or fine tuning. This is the score for BERT F1 score. So you can clearly see there are also implementation in that scores. Also for ROG 1, ROG 2 and ROG 2, ROG 1, ROG L, and this is the final comparison about the baseline and the fine tune. You can see it's about overall 22% increment in the accuracy. So the highlighted is the fine tune version and the normal font is the baseline version. So you can clearly see it's about more than 20% accuracy I got. So now let's see, like this is the data set. If anyone is working on the LLM for medical purpose, they know how good is Met QA data set. Like many people use their data set for like the state of art, or maybe if they want to compare their answer. Actually that data set is closed-ended question, so you can clearly see my model got 97.35 accuracy above the all models. This is a confusion matrix, so you can see how good my model is. So for example, the true classes, and actually the data set is labeled with yes no classes. So for example, you have to give the summary and the answer, and that model will give you the answer in yes and no. So this is the confusion matrix from there, and I got approximately 97.4% accuracy if I round off. So my key contributions are: first, I create the very first doctor focused question answer. Then I evaluate 6 different LLMs for domain adoption. Then I add the novel evaluation matrix, which is UMLS F1 and ICD F1. After, demonstrate the generalizability and the high accuracy. So this is the conclusion and the future work. in conclusion, I already told you, like, I create the very first doctor oriented data set. And then in the future part, first of all, I'm planning to enhance enhance my data set by collecting the data from different hospitals, and then I want to explore the reinforcement for human feedback, so it will directly input for enhance relevancy and usability. Then I want to use that my model with clinical decision support system for real time. And after, I'm trying to collaborate with Pakistani hospital, like it's not a big hospital, but it's a small hospital where I can use that system and test that system. So this is the web interface, like how you can use that website. I will show you that later. This is my work. So thank you for giving me that opportunity. So if you have any question, you can ask. Then I will. Thank you. Okay. So this is kind of interface. Here you want to select the model, and then there is a patient's summary. So you can select the patient summary. There is a pre-write question. You can write anything what you want, and then if you click on thinking, it will give you the complete answer. So from that answer, it's only from that report. The model will not generate anything, because if it generate, it will go for hallucination. So that model will just take the data from that summary and then generate the question, generate the answer. You can see any like the. Can you zoom?